Adhere Health CEO Jason Rose helps Medicare Advantage plans boost their star ratings by improving medication management and CAP scores. After a stint working with adolescent schizophrenia patients, he's been in healthcare technology his whole career. He was an early employee of Cerner and spent 8 years at Inovalon building products and helping the company go public before taking over at Adhere. In his spare time, he works with Operation Song in Nashville, helping military families tell their stories through songwriting. He also walks many miles a day and listens to audiobooks. I'm David Williams, host of the Health Biz podcast and president of Health Business Group, a strategy consulting firm that helps healthcare and life sciences companies like Adhere Health develop robust growth plans. Reach out to me, dwilliams@healthbusinessgroup.com, if you'd like to discuss strategy for your company. And finally, please do me a favor and subscribe. Well, Jason Rose, CEO of Adhere Health, welcome to the Health Biz podcast.
Thank you very much, David. Looking forward to the discussion.
Great. Well, we were speaking a couple of years ago on the podcast, and you're talking about adherence, and it was so impressive what you were doing. I figured that all the adherence issues would be solved by now, but even if you've solved them and haven't had a chance to implement them everywhere, I guess.
Yeah, there's $4 trillion healthcare U.S. healthcare market. There was an endless amount of opportunity to improve costs and improve experience. So I think that is a life goal for me and for many others.
Now, that sounds very fair. Well, we'll jump into some of the current day soon, but let's actually wind the clock back a little bit and just talk about your background. What was your upbringing like? Any big childhood influences that made you who you are?
Yeah, absolutely. I thank you for that question. I don't get that a lot, and it is a great question. So I had great parents growing up. Both of my parents were strong supporters of me personally, my brother as well. A very nice upbringing. My dad was a corporate executive in technology. Back then in the 70s and 80s, it was more about telecommunications and satellite communications. And so my father grew up with IBM and Xerox, and then went off to build his own business. And that made a huge impression on me personally, using technology to advance communications, and using technology to advance healthcare. Plus the entrepreneurial spirit. So I think, looking back, that had an incredible impression upon myself and what type of person I want to grow up to be, and also how I believe I can make an imprint on society and the things that I focus on in my career.
That's terrific. And what did you decide to study once you left home, and what was your kind of early career launch about?
Yeah, I actually had a hard time figuring that out. And early on, I knew I wanted to do something in healthcare. So what my initial path was an interesting one. Was actually in psychology. So at one point, and I get a lot of chuckles when I talk to people about this nowadays, given what I'm doing now today, is I actually thought I was going to be a psychotherapist for mental health patients. And so I got a degree in psychology, and then I went to work for a mental hospital, closed door, locked door, inpatient. I worked with chronic mentally ill patients. These were mostly adolescents. That this was the last opportunity for them, it was a hospital called Chestnut Lodge, which was really an internationally famous hospital in Rockville, Maryland. There was books written about it, including "I Never Promised You a Rose Garden," which was a classic book about a 16-year-old, 17-year-old schizophrenic growing up with mental health issues, and as a resident of this particular hospital system. And I realized that was not the place for me to build my career, because I really thought I would be better off in the business world, and I thought that I could make a larger imprint on more populations than one-on-one. And so I'm sure that there's lots of doctors. I'm not a doctor, who probably have experienced similar things when they thought they were going to be a doctor, then they decided that they wanted to get into more business orientation, but still in that healthcare profession. And so I definitely had a huge imprint from that experience working for 3 years in behavioral health, directly with mental health counselors, psychiatrists, and the patients themselves. And that made a big imprint on how, frankly, what type of business that I would like to be a part of, and how to collaborate with others, deal with stressful situations. There's nothing more stressful than what I dealt with back in the day, and really appreciated that early experience in healthcare. From that, when I decided I needed to get into the business area, again, some things are by luck. I decided to enroll in where I grew up in the DC area was George Washington University's business school. And I found out that you could get a portion of your education paid for if you actually worked for George Washington in some way. And so I found an opportunity, really by luck, that the health system had an opportunity in the technology department. And I found an opportunity to get that job and get a big portion of my education paid for, which was really important to me. And interestingly, this is in the early 90s at this point. Because I was in the technology department of the medical center, and because I was getting this degree in healthcare business, it was very obvious to me that technology could have a big imprint in the future of healthcare and making it more efficient, more effective. So I went to the dean of the George Washington University School of Business in the program I was in, and I asked him. I said, I want to get a degree in healthcare tech, and they said, well, there is none. I said, well, how about I custom create one? Would you approve it? And they allowed me to do that. So I actually custom created a program to focus on strategic technology innovations in healthcare. At that point, everyone back in the 90s were focusing on acute hospital stay, acute hospitals and regulatory areas, but I really wanted to be in tech. And so as a part of that degree, I was required to do a residency or some sort of an internship with a company. So I'm sure you're familiar with Cerner Corporation, David, and most people are nowadays. Second largest EHR, electronic health record company in the world, next to Epic. So again, tenacity and decided to approach Cerner, and I effectively became the first graduate intern, maybe the only graduate intern. I say that jokingly, but the first graduate intern for Cerner Corporation, and really credit that experience back in the mid 90s that set off the course on my entire career of healthcare tech. And so I would say I'm probably a rare person. At my age, I'm 50 now. I've been in healthcare. I've been in business, rather in a career for nearly 30 years, and almost 100% of that is healthcare tech, and that's unique today. And so I feel like I've really stuck to my career, and I see a lot of upside in the future.
No, that's good. Well, it sounds like you're really one of the pioneers. I was just a few years ahead of you, probably in the same area. I grew up in Bethesda, Maryland, and actually I dabbled in psychology a little bit myself, only because my father is a social psychologist, and he has a PhD in social psychology. His faculty advisor at Harvard was an old guy named Timothy Leary, if you've heard of him. So he was the one that brought LSD along. And so
Oh yeah.
the good news was that when I was in high school, and people would do
It's a different
drugs,
kind of influence.
yeah, when people were doing drugs to rebel against their parents, I could say, hey, my dad was was with Timothy Leary, so I don't really have anything to prove. And when I was in college and studying psychology with one of his classmates, and the professor was giving me a little hard time, he says, I could tell you some stories about him and his first wife. So maybe he should, ease off and give you an A. So I didn't go into psychology, but I did also go into health tech nonetheless. So it's interesting to hear your story. So let's talk about a little bit closer to the future, since it sounds like you've been doing the same old in a very interesting and innovative way for some time. And let's talk about Adhere Health. So by the time you joined up there, you've been in the space, relevant space for some time. What attracted you to the company, and what was kind of the focus of the company at the time you joined?
Stepping ahead a little bit past Cerner, if you look at my background, I've also been in the value-based care area since mid 2000s, and so that was, I'd say, probably the beginnings of value-based care. And I spent a good deal of my career, nearly 10 years at Inovalon. Back when I started, it was a startup, a very small little startup company. It was actually called MedAssurance when I joined back in '08. And I had the opportunity to build many of the products that still exist today with that company. I was able to be responsible to rebranding the company from MedAssurance to Inovalon. I think it was in 2012, and went through the IPO in 2015. And now today, I think just a week or two ago, it was just sold. That went from public to private for 7.3 billion. So
Everybody likes those lucky sevens. I saw the Data Van Ciox was also seven. I think I know Elon one just topped it. It's got 7 point something. So seven is a good number. I hope you still have a
yeah,
little bit of the action there.
yeah, I went on to other things a couple years ago, but I couldn't be happier for in all candor, one of my biggest mentors in my life was Dr. Keith Dunleavy, who's the founder of Inovalon. He and I had a nice brief text exchange that morning, and I was congratulating him and telling him how important he was to me in my career. I decided to leave Inovalon back in 17 to join Adhere Health in 18. Really, because number one, I wanted to, I really wanted to be a CEO. That wasn't going to happen with Dr. Dunleavy being there for such a long time. And number two, I wanted to find an opportunity to focus on quality outcomes and medication adherence and medication optimization. And because I believe that there's such a strong influence and really untapped influence on how medications can really improve quality of care, cost reductions, value-based care reimbursements, and those types of things. And so Adhere Health had an awesome product, really unique in that space. And that would be the first reason. The second reason is I love Nashville, Tennessee. And I had lived here for 10 years, moved back to the DC metro area with Inovalon for 10 years. And I really wanted to get back to Nashville. So had the opportunity to work in a payer-focused company that's tech and in Nashville, and it couldn't be better. What does the company do? Your question on that, David, is if you think about a broad brush, so 16% of the U.S. healthcare spend is related to medication adherence issues. That's over $500 billion every year. And this isn't numbers I made up. These are actual published research numbers. It's the Annals of Pharmacotherapy on 2018 with 2016 data 5 years ago. It's probably closer to $1 trillion now with all the aging baby boomer populations. It's a big number. And most people, when I say that over $500 billion, it's just astounding. And it's amazing to me that all the discussion on price transparency, discussion on premium increases, but what about patients who don't take their medications or don't take them correctly or don't discontinue to take them? Those are the three main areas if you think about adherence. The patient is diagnosed with something and they never took the drug at all. They never initiated it. Two, they aren't taking it adherently, which means typically it's 80% of the year they're refilling the drug. And three, let's say they have a major event in their life. They go to the hospital or something. 40% of the readmissions back to the hospital are related to a medication problem. And so that's the third area, is discontinuing the drugs they shouldn't be on anymore because of contraindications with the drug mix they have. And so that's what Adhere Health does. We're squarely focused on that space. We do it from a perspective of technology base. We call it the Adhere platform. And then we leverage telepharmacy, outbound directed outreach to patients and their doctors to try to overcome why are they having issues, and can we overcome the social determinants of health, or what the cases may be with respect to why they aren't adherent. And that is a big thing for us to tackle.
Now, when we spoke a couple of years ago, one of the things is you're talking about something people they don't necessarily think the problem is so big, they may not consider it. However, there's some smart people at Medicare, and we talked a couple of years ago about the Medicare star ratings, it was very important for the Medicare Advantage plans. And it sounds like they really were emphasizing the importance of medication adherence, and that was really how you would get good star ratings. Is that still the case? And does that indicate that there's good sort of understanding from the folks in Washington or Rockville about the importance of medication in driving cost and outcomes in healthcare?
Yeah. So as a part of the Affordable Care Act, a lot of people don't realize that it had a major impact on Medicare Advantage and also Medicaid too. So if you look at today, what they did was they reduced the premiums for the Medicare Advantage plans. They said we're going to take a big chunk. I think it was 5% discount on the Medicare Advantage premiums that they were collecting. But they said we're going to let you take it back if you can prove that you are amongst the highest quality plans in the country. And the way they do that is completely data driven. It's a complicated set of 50 some measures that changes every year, and the weightings of each of these quality measures have differences. And so if you look at the weighting perspective of all the star ratings for Medicare, it's 52% is related to medications. And so why are they doing that? Well, I think because $500 billion a year are avoidable medical costs due to medication adherence issues. So just to put things in perspective, this past year, the Medicare Advantage star ratings, they call it the QBP, which is the quality bonus pool, is $11.6 billion. So if I'm a Medicare Advantage plan and I can get to 4 out of 5 stars for the aggregate score from CMS, Centers of Medicare and Medicaid, then I will get about $500 per member per year if I reach that 4 out of 5 star level. And that gets you a piece of the $11.6 billion. If you don't get to 4 stars, it's a big problem. And so what happens is that money doesn't go line the pockets of the health plan executives. What it actually does is it actually must be directly inputted back into your product, your Medicare product that you're offering to patients. And so there's studies every couple years that demonstrate the importance of how good your product offering is to a beneficiary prospect of choosing your plan and not plan. I truly don't believe that a Medicare patient that is choosing plans knows or even cares about star ratings. It may be publicly available. I don't think they really know. What they do know is what is in the benefit structure for the plan that they're choosing. And so when you have more money to spend, very simple, if you have more money to spend to make your product richer, you're going to get more enrollment. And so the latest study that was by Navigant in 2018 showed that for every star rating a plan has, which again provides more benefits to the member, the prospective member, they get it between 8 and 12% increase in enrollment. So that's massive.
Yeah.
So when you're thinking about a competitive environment for Medicare, and the way they make money is more membership growth. The way my company makes money is I get more health plan sales, more membership. The way the health plan makes money is they get more members, and they do a really good job on their medical loss ratios and their star ratings and reimbursements. So if they're below 4 stars, they're providing less benefits and less opportunity for their members, and therefore they actually have less membership attracted to them. So it's a huge deal for any Medicare Advantage. And so what every year they change, they make it harder and harder. So these all competitive with each plan. So you're either for each measure, each of the 53 measures, there are 5-star cut points. So there's a 1-star cut point, 2-star cut point, 3, 4, and 5. And based on how all the health plans are performing on that individual measure, so it could be diabetes adherence, it could be statins adherence or RAS adherence, or patients with diabetes, are they taking statins? Or patients with cardiovascular disease, are they taking their statins? Or have you done medication therapy management for these patients, or pain assessments and med reviews? So it is dozens of these complicated measures. Each measure is compared nationally. There's no regionalization. Each measure is compared nationally against your peers. And depending upon how well you do on this particular measure that is not graded on the curve, you will get an aggregate score. And that's how the whole system works. And every year it gets harder.
That's good. Well, that's good for the patient. You said the patient don't necessarily pay that much attention to the star ratings. They may not know about it, but their feedback is sought through the CAPS survey, and that plays in as well. Can you talk about what CAPS is and how, whether that's changing in terms of how it's being used going forward?
Yes, absolutely. So the CAPS survey scores is really, you can characterize it as patient experience. And so what it is that the is ARC, AHRQ. If your audience is familiar with AHRQ, is responsible for the CAPS measure scores. And what happens is that every year, regardless of the Medicare Advantage plan size, that plan is going to have a certain number of members, specifically 800 patients, that are going to get surveyed on what's called the Consumer Assessment of Healthcare Providers and Systems. That's CAPS, CAHPS. And so that is patient or member experience on their plan, on their doctor, and their prescription drug program. And those are the three categories. And this year, there are 8 CAPS measures. They're split between Part C and Part D Medicare. And then there will be 800 patients. If you're a 1,000 member plan or a 500,000 member plan, you get 800 people. They're statistically valid significance to show whether or not the patients are getting good experience. So the big change here, that's been around a really long time. The big change here is that starting in 2021, they took that CAPS measure, the patient experience, and they said this and medication issues are the most important things. And so it's now 32% of the overall weighting. They doubled the weighting for experience. So what CMS is really saying is that it's not enough to just do well on your medications. It's not enough to do well on some customer-related appeals and grievances and things like that. We're now really putting a heavy emphasis on patient experience. And a lot of the plans think it's very unfair, but I can tell you what the news that just came out in the past couple of weeks, as the plan preview ones came out, the private information that come from this CMS directly to the Medicare Advantage plan on what their view is of the star rating scores that they're about to release in October, is that if you think about, there's 8 measures, and there are 5 cut points per measure. So that's 8 times 5 is 40. So it means there's 40 cut points. 22 of the 40 of the patient experience CAPS measures went up. And so that caught everyone off guard, most of everyone. We were frankly expecting it would happen and we did white papers on this and we built solutions around this. Some plans did a really good job on this, and that's why they went up. The cut points went up to 22. A lot of the plans did not do well on this, and they got caught flat-footed. So now a third of your score is related to patient experience, and you haven't been putting emphasis on this already, you're at risk of losing your 4-star marker, and that's worth it's really literally worth hundreds of millions of dollars depending upon the size of the plan, and also market share. So it's a really big deal. Over the course of time, CMS has already indicated they're going to make it harder to get patient experience, including things like NPS scores. So it's not going to get easier; it's going to get harder.
So what are they doing now? I mean, obviously they care about it because it drives right to their bottom line, plus just even some pride in how they're being evaluated. Any kind of steps they're taking, either sort of quick fix or long term?
Yeah, the way we approach it is it's interesting is how we approach adherence as well. So when we reach out to a patient on dealing with patients that are not adherent to their medications, what we're doing is we're not calling and say, "Madam, you're not taking your statins. Can you please pick up your statins at the local Walgreens or CVS?" Click. We're not doing that. That's not going to get you anywhere. There's a reason why these people aren't taking their drugs. And I like to call it the Maslow hierarchy of needs of healthcare. So that's food insecurity, that's safe shelter, that's transportation, that's health literacy, that's access to your medications. It's now in today's day, it's vaccination hesitancy with respect to COVID. So these are the core basic issues. Some like to call it social determinants of health. These are the problems that are causing people to not be adherent. They can't afford it. It's not their life's priority. They have other things in front of it. They don't understand why they should take it. They just need some help. They may be in food deserts. They may be in pharmacy deserts. There's many reasons. Every patient is very different. And so when we're reaching out with our clinical team, we have anywhere between 500 and 1,200 given the time of the year. These are all employees of ours and employed clinicians, licensed clinicians. We're not reaching out and just asking them to just get their medications. We're trying to overcome those barriers of care. Help us understand what's causing this issue. Do you understand the medications that you're on? Can we help you overcome things that are more important to you? Might be food. So, for example, one of our newest partners is called U.S. Hunger. They do shipping of produce direct from the farm to the doorstep of duals and Medicaid patients. It provides them with dignity. It provides them with not pre-processed food, but actually groceries right from the farm, very fresh. I actually got to experience it myself. It's a beautiful white box, and gives them the opportunity to go cook for themselves because they know how to cook. They just don't have the money to spend on the groceries, or they don't have food deserts and things of that nature. And nothing against McDonald's, but at the end of the day, it's not going to help a diabetic get to better care. So that as we overcome those kinds of issues, we use Aunt Bertha, which is a great technology platform to find other community social service opportunities that close these SDOH gaps. We do that so we can get them adherent on their drugs. So you think about patient experience, everything I just said, although it was related to it was related to adherence, and overcoming vaccination access issues and hesitancy issues, it also helps the patient experience. So what we did was we took that solution and we said, okay, we're not going to just apply this to specific drugs that CMS has denoted as really important medications for cardiovascular, hypertension, and diabetes, which are the three adherence measures and star ratings. We're looking at the entire population because for patient experience and CAPS, it's 100% of the population that could be surveyed. So we have different analytics and algorithms that can detect who is likely to report back to CMS poor experience. And what we do is we reach out to those patients with a similar solution. Help us understand. We know already they may have epilepsy. They may have MS. They may have HIV. It may be many reasons why they have reasons that we would call them. We use that data to influence the right people to call that will likely give poor experience, unengaged patients, et cetera. And then we reach to find out what's going on in their world. How can we help? Food, water, shelter, access, and we build a plan of care for that patient. We work with the plan and the case management team to understand what this plan of care is, and we are action driven. We tackle these issues right there on the spot. And it's something that we're starting to get a tremendous amount of interest in. We've got some early adopters from earlier this year, and that's a big part of, I think, growth for our company, and really, frankly, more importantly, the focus of what any MA plan should do in the country.
Well, Jason, that's really exciting to hear that, and good progress from the last couple of years ago when we spoke on things you're already working on, and then helping, I think, especially as this attention to the CAP score has gone up. I want to end the podcast asking you a couple of bring it back to kind of the personal side of things. I noticed in reviewing your LinkedIn bio that probably around the time we last spoke, you started to get involved in something called Operation Song. I want to hear about that. And also, if you've had a chance to do some reading over the past months and years, and any books that you would recommend for listeners, or any books you recommend people stay away from too, those are also helpful.
Great. Thank you so much for asking about Operation Song. So I'm a busy guy. Lots of people are busy, but it's really important to find other avenues to give back, and to find something that has a calling to you that's outside of work. If anything else, just to give a different perspective and more appreciation for things in life. And so I had the opportunity to come across this charity, which is Nashville based, but it's a national charity called Operation Song. And it really fits me very well, because it's very entrepreneurial. It was a startup, and it's innovative and differentiated. And what it does is it's a charity that's focusing on military and the veterans and their families who may have post-traumatic stress disorder issues from life's events. And because this is Nashville, this is Music USA, Music City as they call it, we have a tremendous amount of talent here. Not just country music, by the way. We've got lots of different genres here. And what we do is we actually pair up the vet or their family with a very accomplished, often Grammy Award, Dove Award winning artist, writer, to meet each other. The veteran or their family member can talk. These are Gold Star moms and dads and things of that nature as well. Talk about whatever they want to talk about. It could be about the actual issue. It could be about just something they want to get off their chest. And what they do is they talk about this issue with this very accomplished writer. They write a song together, and then they publish that song. And it's an incredible, moving experience when you hear these songs. So if you were to go on the App Store, you would see Operation Song is one of the apps. There's New Music Monday, come out with new songs. We've now done about 1,000 songs. That means we've worked with about 1,000 veterans, which has an impact to probably 5-10 times that people. And these are some of the most powerful songs that you'll ever hear. Recently, we were on CBS News with Norah O'Donnell. We were on Huckabee. We've been on Fox. We've been on Military Times, Washington Post, Forbes. So we're getting a lot of momentum, and we're one of the only non-military, non-government organizations that work directly with the Veterans Association, Veterans Administration, excuse me. So they provide us with funding, and we also pair up the vets that they send to us in retreats. We do, because of the pandemic, we do virtual retreats, so to speak. But you'd be impressed with the writers that are working with them. They're just incredible people, and it's just a wonderful thing to help our military and our vets.
Do you have time for reading also, or just listening to the songs? Yeah.
Yeah, absolutely. I'm sorry. You know what's interesting is, so I first of all, I love to read, but everyone has their own style. So I read on paper or on my phone, or books. I like to read healthcare industry or business, Wall Street Journal, things like that. But when I'm reading for more pleasure, I do a ton of Audible. And whether I'm traveling or now because of the pandemic, I've got this, I guess, new hobby of mine is walking. So not everyone can do this, but I walk a ton. So 3-4 days a week, I'm walking 7-8 miles around very hilly Nashville in my neighborhood and outside my neighborhood. And I'm listening to books, or I am talking on my one-on-one conference calls and things of that nature. So I get my fix from Audible when I have time to do some pleasure reading or listening in this case. And so I guess a few books. The one I'm reading right now, which you surely have heard of before, is a book on Lincoln. And I'm almost done with it. It was a 35-hour book. I've got 5 hours and 52 minutes left. I'm looking at my phone. But it's by Doris Kearns Goodwin. It's called Team of Rivals. And it's about Abraham Lincoln and what he did to overcome his rivals in the Republican Party, which was brand new back in the 1860 timeframe, to win the nomination, ultimately the presidency, and what he was saddled with the Civil War and defeating slavery and all those types of things. And so what he did was he took his rivals and he put them in his cabinet, and it's just an amazing bold way to do the right thing for the country. And so that would be one book. The other thing I would say that I've done a lot of, and I credit my wife for helping me get more into this, is I like to meditate. So probably not every day, but probably 3-4 days a week, I try to find time to meditate. It could be anywhere from 12 minutes to an hour a day, where just either guided meditation or listening to different types of music that puts you into that deep meditative state, and reading books around meditation. And that gives me a reset personally, and allows me to kind of focus on the things that are most important. And I would heavily recommend things like that. If you want to start off something easy just to get your feet wet, I would recommend getting the Calm app. If you have American Express, it's free. It's like $10 a month or something. But when you get more advanced, Audible and other books and things on YouTube, it's a really great place to get some inner peace and also focus. Other than golfing, and when I used to do karate, it's really, to me, it's a good kind of white space to really be free from other life's issues.
Great. Well, Jason Rose from Adhere Health, I want to say thank you very much for being a guest today on the Health Biz podcast. I'm glad that we had a chance to catch up again after a couple of years, and I hope to see you in the near future.
Terrific. Thank you so much, David. Look forward to it.
You've been listening to the Health Biz podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.